we have that are focused on telehealth. Today's session is titled Effectively Utilizing Telehealth for Vulnerable Populations. I do have everybody muted and we'll have you muted throughout the webinar until the end. If you do have questions or you want to make any comments prior to that, please put it in the chat. At the end of the presentation, I will open up everybody's mics and allow you to open your own mic to make a comment. If you would like. All right. Well, today, as I mentioned, we're very fortunate to have Dr. Anderson with us. I will say that we had a little bit of a conversation with him prior to the start. He's having some technical difficulties with his internet provider. The other day when we did the check, everything was working great. But if we do by chance have issues that just makes it unreasonably, you can't hear it, we will reschedule with Dr. Anderson. And he has agreed to come back and help us out if it just doesn't work today. But we're going to cross our fingers this is going to work well. So Dr. Anderson is a primary care general internist. He is the director of the Wiseman Institute, which I'm sure many of you are familiar with. The Wiseman was established by Community Health Center, Inc., which is a large statewide federally qualified health center based in Middleton, Connecticut. And we've had several speakers from CHC, Inc. already, and we're going to have another one with one of our other sessions. Dr. Anderson leads a diverse team of innovators, health service researchers, educators, quality improvement specialists working together to improve primary care for the underserved. Under his leadership, Wiseman has grown from a small Connecticut-based institute to a national organization working with health centers, payers, funders all across the U.S. Wiseman's educational program includes Project ECHO, which again, I know many of you are familiar with. His research on e-consults have been published in many journals, including Health Affairs, and has been widely cited, and provided the foundation for the development of the Wiseman subsidiary e-consult company called ConfirMed, which now provides access to high-quality e-consults to over 1.5 million patients in the safety net practices across the U.S. Dr. Anderson obtained his undergraduate degree from Harvard College and his MD from Columbia. He completed his residency training in internal medicine at Yale New Haven Hospital and is a board-certified general internist. Before I turn this session over to Dr. Anderson, just a couple things that I need to go over. I know y'all will be pleased that we actually will be offering CME credit for this session, as well as the remaining August webinars will also have CE attached. So as far as disclosures go, the speaker and the planning committee members have no financial relationship with any commercial interests. The objectives for today are as follows. You can see on the screen there, it's to learn how to utilize different telehealth strategies to support improved disease and care management for vulnerable populations, to understand the impact of scalable telehealth strategies on primary care practice, specialty access, and operational outcomes. And then lastly, to understand how telehealth strategies can be leveraged to address the healthcare needs of specific vulnerable populations who are struggling with either homelessness, substance abuse disorders, living with HIV, hepatitis C, or who experience health disparities secondary to stigma, such as LGBT community. So with that, I am actually going to unshare my screen and allow Dr. Anderson to begin sharing his, and we'll move forward. Thanks, Dr. Anderson, for being with us.
Thank you so much.
Yours.
Thank you, Lisa.
You're
All right,
welcome.
can everybody hear me okay? Let me just do a quick audio check. How's my sound?
Sounds good.
All right, good. Well, let's keep our fingers crossed.
Yeah,
So
absolutely.
this actually is the second time that I've had the privilege of talking with the Community Health Centers of Arkansas. The first time was in 2014, and at that time, I was lucky enough to actually get to come to Little Rock and meet with all of you in person. And I'll say we've done a lot, and there goes my dog barking at FedEx. Perfect timing. We've made a lot of adjustments over the last couple of months, all of us collectively, to adapt to new ways of doing things. But one of them that I really miss is the loss of the opportunity to meet people, to break bread, to talk and see each other in person. There's nothing like presenting when people are in front of you listening and you can kind of read their body language, tell if they're falling asleep or whatever else. But with that all having been said, I'm excited to have a chance to still speak with you using hopefully using technology. And although I work for a technology company and an institute that's really focused on technology, I don't have any control over Xfinity, and they seem to be giving some trouble today. So for that, should we have any spottiness and stutters or anything, I apologize for that. And Lisa, thanks for the introduction. But I think what I really want to emphasize in the introduction, all of the flowery words and everything, what I really am is an FQHC doc. I was in the National Health Service Corps, and I came right out of I went to residency with the intent of learning how to be a good primary care doc to work with underserved populations. And I've done that ever since finishing my training, and started with many years as a full-time provider. Gradually took on the role of CMO, and really landed now where for the last 10 years in what I think is where I was meant to be at the Weitzman Institute, which is, as Lisa said, an institute that is really focused 100% on solving problems for the medically underserved. There's lots of research and lots of institutes out there, but we are, I believe, pretty much one of the only ones that is focused really exclusively on the safety net and on the patients that you and I and others around the country care about most deeply, because we often collectively kind of get the short end of the stick when it comes to healthcare finance, when it comes to research and innovation, and that's what we're working to fight against. And I want to spend my time today talking about. Let me share my screen. I changed the name a little bit. Right up to the last minute, I was making some edits and changes, but I want to put a little musical theme to this. I'm a pianist, I'm a musician, and I titled this talk From Dissonance to Resonance, Improving Care for Vulnerable Populations with Telehealth. I'll talk a little bit about, you'll see sort of where that theme comes in. We've already talked a little bit about what the Weitzman Institute does. We are part of our community health center, federally qualified health center. It's really an arm of that institute, but we work with people around the country and increasingly around the world to help find solutions to common problems that affect the underserved. And my team did a series of electronic consultations on COVID-19 with doctors in Indonesia last week. So we're expanding even beyond our walls a little bit. So let me jump right in. I practiced full-time for a long time in an inner city practice. I took care of my own HIV patients. I was building capability to really tackle hepatitis C treatment and really tried to, with my team, provide integrated, comprehensive primary care. And I saw all around me issues of burnout, not just amongst my colleagues at CHC, but in primary care more generally. And so, job burnout is described as as really having three key dimensions: overwhelming exhaustion, feelings of cynicism and detachment from the job, and a sense of ineffectiveness and lack of accomplishment. And I really want to emphasize that number three. This was a study that I was looking at. This came out just before COVID-19, but it was talking about professional dissonance and burnout in primary care. It was a qualitative study of people like you and me that had practiced primary care and had a chance to really unload on what was bothering us. So one of the quotes that I pulled out of this article, the participants, felt demoralized by work conditions, undervalued by local institutions and the healthcare system, and conflicted in their daily work. Participants conveyed a sense of professional dissonance or discomfort from working in a system that seems to hold values counter to their values as clinicians. And I read that, and it resonated with me. The sense of dissonance resonated, and it really made me think a little bit more about where does that cynicism come in, and what are the sources of dissonance that we're feeling. I looked up, the word dissonance speaks to lack of harmony among musical notes, but I think more broadly, as it was intended in this article, as a tension or a clash resulting from the combination of disharmonious or unsuitable elements. So bear with me for just a second. Let's see if I can make this work. So listen to this. I hope you were able to hear a little bit of that, and I wonder if anybody recognizes this person or recognizes that piece. But I want to briefly tell the story because I think it's relevant to what we're going to talk about today. So actually, if anybody does know who that is or recognize the picture, go ahead and put it in the chat. So this is Keith Jarrett, and what you just heard was a very brief fragment from what was called the Cologne concert. And the very brief story behind this was Keith Jarrett was a famous jazz pianist who was touring Europe. And he was billed to perform a late night concert in Cologne, Germany. And it was a young teenager, a 17-year-old German woman who had billed the concert and had sold out the Cologne Opera House. And it was scheduled to perform after the completion of an evening opera. So it was a late night concert, and Keith Jarrett arrived the night before, jet lagged. He hadn't slept. He had a backache. He was feeling terrible. And when he arrived that afternoon to practice and get set up, he found on the stage an old beat up practice piano. The Bosendorfer full grand that he expected and that he was accustomed to playing was nowhere to be found. And he stormed out and refused to play. So the woman who had planned the concert said, "Oh no, please, you have to play. We have thousands of people. They're so excited to hear you. Please don't go. Please carry through with the concert. I'll get a technician in. We'll tune the piano. We'll get it fixed up as best we can." And so grudgingly, he agreed. In the piano, as I said, it was a beat up old piano. It had terrible bass sound. The upper registers were very tinny and tingly. And so he had to make some adjustments to the way he played. But he gave the concert. It was recorded live, and it is the #1 selling jazz recording of all time. And it is by many critics viewed to be one of the finest jazz piano recordings ever made. And whether you like jazz or not, or whatever kind of music you like, this particular recording blends elements of jazz and classical music. But he totally changed his style of playing based on the piano. He kind of focused on the inner, on the middle portions, because those tones tended to sound the best. And by adjusting to the conditions that he was faced with and adjusting to the instrument that he had, he produced beautiful, beautiful music. And out of the dissonance of the original piano that he played, created something truly beautiful and wonderful. So hold that analogy in your mind for a bit as we talk about what are we going to do about complex care management, vulnerable populations, and COVID-19. We're going to make some beautiful music. But I put this up. This on the screen is an email that I received back in 2008. This is the email that kicked off my entire sort of research career in the area of specialty primary care interface and e-consults. And you can see, I won't read all of it other than to say this email was written by our frustrated referral coordinator. I had asked her to find a dermatology referral and an orthopedic referral for one of the patients that I was seeing. And as she goes on to point out, none of the orthopedics in any of the surrounding hospitals wanted to see the patient. They basically said, sorry, send them somewhere else. They referred them up to the University of Connecticut, which is our public funded hospital, which was 2.5 hours away from where this patient lived, even though there was a big, beautiful orthopedic center 5 minutes away. And for dermatology, same problem. There was nobody able to see that patient. And as she says in the bottom, can my job get any harder to do? Multiple question marks. And that really got me thinking about all the hundreds and thousands of times that this exact same scenario plays out for primary care practices, for providers like me and like you working in under-resourced practices and in communities, states and regions where patients with Medicaid or patients without insurance get the short end of the stick. This is my colleague, Dr. Lecce, who has been practicing primary care for almost 50 years. And this is how he feels when he gets an email like that. And I think this on some days is how we all feel. And this is dissonance. The system is not sharing the values that we have. I have a needy patient, needs to be seen, and somebody is telling me for financial reasons, sorry, we won't see that person. And we know from the research that up to 35% of all the people that we see have a request to see a specialist. And I know from my work around the country and in my own practice that that doesn't go well often when we try to make that referral. This is Yale New Haven Health Specialty Center that I like to talk smack about because this is the place that sent that email saying, sorry, we don't want you. And so what I end up facing and what my patients end up facing is long wait times, having to travel to distant sites, taking time off from work, duplication of work because our communication is poor, substantially increased cost to the healthcare system, and recently COVID-19 exposure. Who wants to go into the academic medical center today? So this is the piano that we're playing on now. Every time we try to refer somebody, we make beautiful music in our clinics. We provide behavioral health. We have on-site dental, the community health centers. We have our UDS scores that show we provide among the highest quality primary care delivery that you can get anywhere. But we run into unbelievable dissonance when we engage with the larger healthcare system. And now we have this new thing called COVID-19 that has taken a bad situation and made it worse. In our state, and I suspect similar to you, many of our outpatient practices have closed. Many of our specialty care practices doing non-urgent procedures and things have closed or have markedly curtailed their work, and everybody is in survival mode, either deferring or delaying the things that they need to get done. And so my patients are not getting the specialty care that they need. Which brings me to really what I want to talk about today. Out of this chaos, out of this kind of semi-disaster, we have an opportunity to stop and say, wait a minute, some of this doesn't make sense. We can do better. We have the tools and we have the approaches to do something better than we were doing before. And coronavirus, COVID-19, may provide the vehicle to help us to do that. I think this is the opportunity for us to think differently about what we're doing and take advantage of some of the new legislation, some of the new rules, and the new openness and willingness to think about telehealth to make a better system than we had before that's built on a strong primary care infrastructure. So literally overnight, everyone's talking about telehealth. We've been trying to implement telehealth in a variety of different ways for the last 10 years, and despite the fact that the technology exists, the pace has been slow. Just before COVID-19 hit, a study showed that only about 15% of practices across the country were really doing any kind of significant telehealth. That number is now 95% of all the FQHCs in the US now say that they're using telehealth. This is what I call the telehealth ecosystem, and a lot of the things on here I'm not going to talk about. I know many of my colleagues from CHC have talked about some of the strategies we've employed to do direct-to-patient synchronous telehealth, which you can kind of see here in the middle. Not going to talk store and forward. Patient-involved telehealth is more like what you can do through the patient portal. Not going to talk about remote monitoring. But I do want to start talking about clinician to clinician. And the reason that I'm going to talk about that particularly relates to scalability. So before COVID-19, we did not have enough specialists willing and able to see the patients that we refer from FQHCs. Now, with everything that's changed, we have even fewer specialists able and willing to see the patients that need to be seen. So direct to patient telehealth with a specialist is not a strategy that I'm going to spend a lot of time talking about. Some practices are fortunate enough to have access to, say, a cardiologist or endocrinologist who can connect directly by video to their patients, but it's not scalable, and there just isn't that much access. If you're lucky enough to have that, great. But I'm going to talk about strategies that help support us, the primary care providers, to take care of more things, to manage more aspects of our patients' care, and to really, I guess, move into the full scope of primary care that we were trained to do. And those really are more the store and forward technologies and the technologies that help us to practice with confidence in new areas. And so this is a model that I made a couple of years ago, and I call it the specialty interface pyramid. We collectively are providing advanced primary care. And many FQHCs have really comprehensive care teams providing great integrated care in addition to, oh, sorry, I just lost my screen share. In addition to on-site behavioral health, some of us are doing dental care, but really team-based advanced care is what we are trying to do to provide good care to the most complex patients that you can find. Many of us have moved into live telehealth. Some of us are using home monitoring, our patient portals, but this really combined is what advanced primary care is all about. But even with all that, we need help from specialists sometimes. And so at the point at which a primary care provider or primary care practice needs the support of a specialist, there are multiple modalities to get the advice, the guidance, and the input from a specialist that you need. One of those ways is e-consults, which I'm going to talk about quite a bit. Project Echo, Lisa mentioned, many of you are already familiar with, kind of related to e-consults, but as you know, a video consult discussion about really complicated things like Hep C or HIV or medication-assisted treatment. Direct specialty telehealth when it's available, and then ultimately the face-to-face. But the face-to-face specialty visit should be the option of last resort when none of these other methods will work. And if we can layer in these elements, we can make sure that when we are sending patients in for face-to-face, it's only when they really need it, and we can use those scarce resources when they're most needed. So this is what it looks like in another way. You have a primary care provider seeing a patient here in person or by telehealth. Let's say it's a patient with possible Hep C, and you're wanting to decide whether or not this is somebody, what kind of workup you should do and whether or not they might be eligible and appropriate for Hep C treatment. Or maybe it's a patient with type 2 diabetes who you have on 2 oral agents and their A1C is 8.5, and you want to make a decision about whether you should add a third agent or move to insulin or whatever. I can make a million examples of when a primary care provider would like to consult with a specialist. You could send them into Yale New Haven Health Specialty Outpatient Center, and that's what we've traditionally done. We've sent 35% of our patients on any given day get sent to Yale New Haven Health Outpatient Specialty Center. You could join Project Echo Hepatitis C or HIV and work with those specialists to gain the ability to manage and to evaluate that patient with Hep C, and you could present that case to them live if you had some specific questions and take on the management of Hep C. Or you could send an e-consult to this nice doctor who is online answering questions. We'll see the questions that you submit, the information from your EHR, and send you back advice about the most appropriate next step. All 3 of these tools in our armamentarium can go an enormous way towards increasing what you're able to do for your patients and improving their outcomes. So let's talk about them individually. I want to show a couple of examples. I've spent a good part of the last 10 years really thinking about and working on the topic of e-consults, and we've done a lot of research. I'm going to share just some of the very high-level overview of some of the findings that we have, but I want to show a couple so you can get a feel for what these are. Some of you may have experience with e-consults. What I've seen nationwide is these have been taken up pretty aggressively in California, in Washington state to some extent. Many of us in the center of the country, in the South, and even up in the Northeast where I am, have been late to the game, and these are not that common yet. So here's one which you may have had a chance to read already, but if you can see, it's a case of somebody who has a tremor. Intermittent, increasing in intensity over the years, tried a lot of different things, has a history of alcoholism, but has been sober for 10 years, and the primary care provider is asking for some advice about next steps. What you don't see behind this is the neurologist that this was sent to also had the most recent clinical note, the med list, the past medical history, and the physical exam that the provider had taken care of. So they had elements from the chart so they could see what the workup had been in addition to this clinical question. And if you look through the response, I won't read through everything, but the neurologist has given some guidance on what to look for next time they see the patient in a neurological exam, has made some comments about the role of anxiety, has reviewed the medications and asked a couple of key questions, and then made recommendations for a couple of different things that might help, including some medication changes and some further workup. So you could have sent that patient to Yale New Haven Health Specialty Center, waited 2 months or 3 months to get in to see a neurologist, and they could have done all of these things. But now I've got this advice. This came back in 24 hours. I can call the patient, or next time I see them, do these things and try the next, the recommended treatments that they have. And in so doing, do a lot of really good things for the healthcare system. Let me show you another one. And again, I won't read through all of this, but this is an interesting ID consult. This is actually fresh, just a couple of days ago. We got this in from a PACE clinic out on the West Coast. This patient had chronic complicated UTIs, multi-drug resistant, on prophylactic meds, nitrofurantoin, and notes what the urine culture was positive for Klebsiella, and talked a little bit more about their treatment and asked for advice. And without reading through this, what I can tell you is the infectious disease doctor went through step by step and reviewed the imaging that was sent over, the resistance panel, the profile that was sent, and made specific guidance, gave specific guidance and recommendations for how to treat the patient in the next step. And one last one, which is really relevant for today, this is a COVID consult we just got. 33-year-old female with COVID who was positive twice, had 2 positive COVID tests, works in a nursing home. The nursing home is requiring a negative test result before a patient restarts work. The patient is asymptomatic. The primary care provider is asking, what should I do if I test her and she's still positive, even though she's asymptomatic? And the infectious disease consultant goes through and makes recommendations and guidance about back to work. And so, we get lots of clinical cases, but we also, with e-consults, get questions like this, asking for guidance on things, from as varied as a back to work recommendation. And so these are just a couple of examples that I think demonstrate what e-consults and what asynchronous telehealth, as I'm describing it, really can do. And what our research has shown is up to 45% of all the patients we send for a face-to-face visit don't need one. It doesn't mean they don't need something. It doesn't mean they don't have a specialty need, but it means that the face-to-face visit at the top of that pyramid was not needed, and that there was another modality that could have provided what was needed to best care for the patient. So at Community Health Center, we implemented e-consults the way I've described them. Actually, we started back in 2010, did a series of tests and studies. We actually did a randomized controlled trial to really test how this worked and make sure it was safe. And then we implemented it across all of our health centers in Connecticut for all major specialties. And I thought it was really interesting. This popped out at me when I looked at our CAPS score. This is our annual CAPS survey that's administered by our state Medicaid plan, and had a lot of data, tons of things. But I zeroed in on 2 things. 2 of the CAPS questions speak to patients' perceptions about specialty care. So you can see question 20, specialists, blah, blah, blah. In the past 6 months, did you see a specialist for a particular health problem? And in 2018, you can see our provider, the composite response was 41%. In Community Health Center, this is for all of our health centers, didn't change. At Community Health Center, 40.5% in 2018 said yes, 38.7% said yes in 2019. What did we do between these 2 years? We implemented e-consults. That's not a huge drop, but I was surprised that we picked up a signal at all with a CAP, something like a CAP survey. And you can see no went from 49.5 to 61.3. But I thought equally interesting was in the past 6 months, how often did CHC seem informed and up to date about the care that you got from specialists? And this really speaks to the communication back and forth between the specialist and the primary care provider, which e-consults were supporting. Always felt that they were informed, went from 80 to 84.5%. It doesn't prove anything, but it kind of got me excited thinking that we were onto something. So we did another study, and I'm going to go a little bit quickly through these because I don't want to bore you with too much science. But one of the most popular consults, the number 1 utilized e-consult across the health center is dermatology. And that's because there's a 1-year wait to get a patient from a community health center and to see a dermatologist in the state of Connecticut. So we use it for all of our dermatology. We get multiple pictures using a point and shoot camera, 3 angles. We submit them along with the clinical information. And so we did a look to see what happened. So before we had e-consults, in a year, we did 1,258 consults. And you can see in the bottom left, the blue circle is the most important one. Only 11% of those 1,258 patients ever got seen by a dermatologist. 41 never got an appointment because no one would see them, and 48% by the time their appointment came around missed their appointment for a variety of reasons. So only 11% ever actually had eyes on the rash that they were referred to. After we started doing e-consult, that number went up to 66%. Either got seen by the dermatologist or got the diagnosis and the treatment they needed through the mechanism of the e-consult. So in 1 year, we jumped from 11% to 66% getting the dermatologic care that they needed just by sending 3 pictures and a clinical note to a dermatologist at the University of Connecticut. The second paper I want to share, again, briefly, was after we showed, gee, this really works. It gets people the care that they need. It reduces the number of times they need to go into the academic medical center. We needed to convince our state Medicaid that this also was financially viable. So this is a paper that came out in the American Journal of Managed Care. We got Medicaid claims data on all the people who had had an e-consult for cardiology. And what this shows, this is, apologize, sort of a garbled graph. The line down the middle is the date that a patient was referred to a cardiologist. The dotted line is if they were referred to a provider who had who sent them for face-to-face. The solid line is if they were referred from a provider who had access to e-consults. This is total cost of care month per month. And basically what it showed, the amount of dollars in this gap that opened up the day they were referred was $500. The doctors who had access and the primary care providers who had access to e-consults cost on average $500 per patient less than the providers who didn't have access to e-consults. And I won't go into the details of the study unless anyone has questions. This was enough to convince Medicaid to start paying for e-consults. So Connecticut Medicaid was the first Medicaid program in the country to authorize direct reimbursement for the CPT code 99451, which is an electronic consultation. Many states have now followed suit. Many payers have followed suit, and every month a new state adds themselves to that list. I was just looking, Vermont and Maine just added themselves to that list. California is on it, Colorado. Many other Medicaid programs are realizing that this helps patients, helps access, and saves money. So the final study we did to really make the point home is instead that previous study was just cardiology. We extended the evaluation to 4 other specialties and showed a similar pattern. Dermatology, endocrine, GI, orthopedics, all were saving money compared to patients who didn't get an e-consult. Interestingly, orthopedics had the most savings, even though the rates of sending them to orthopedics were much less. But you think about the number of MRIs we prevented or the number of knee arthroscopies that weren't needed, and you can understand why the savings was so substantial for orthopedics. But all 4 showed clinical savings. And right around the time this came out, Medicare, CMS, authorized as part of its expanded telehealth coding, they authorized reimbursement through CMS for all Medicare programs for e-consult as well. So some of this work really helped build the case for not only this being a good clinical tool for FQHCs in rural locations, but being a good tool for the healthcare system to make things more efficient and to save the system money. So who pays today? State Medicaid, as I've mentioned. Many commercial managed care plans. I know Arkansas does not have Medicaid managed care, but many states that do, the MCOs are starting to pay for this. Many ACOs are paying for it, IPAs, all sorts of different groups depending on how healthcare is organized region by region. And we're seeing a lot of what we call fully capitated FQHCs and primary care groups that are taking full risk from Medicaid are actually starting to pay for e-consults because it saves their system money. Just across the border from you in Texas, we have 2 foundations. Methodist and St. David's are both paying for us to do e-consults for FQHCs across the state of Texas. And we have some grants from HRSA. We are doing e-consults with a group called Mainline in their school-based health centers. They've only done a few because they're kids and they tend to not be so sick, but that was funded by HRSA. And so there's a variety of different ways to get these paid for. Some health centers have gotten FTC telehealth grants this year as part of the COVID emergency package, and they're using those to pay for this tool as well. And then lastly, before maybe having beaten this topic to death, this just came out from the Milbank Quarterly. Comprehensive review of all of the evidence and literature for e-consults. And as they describe it in the title, a triple win for patients, clinicians, and payers. And their conclusions were e-consults improve access to specialty, they lead to more efficient use of healthcare, they have high patient and clinician satisfaction, and they lower the total cost of care. And they featured many different systems around the country that are doing this. We were in it as well. We were excited to see our names in it, but a lot of it was built on research that's been done around the country and around the world. So I want to pivot a little bit. I know I'm going to speak less about Project ECHO, but I think it's important. I know many of you are familiar with it. There are many opportunities to join Project ECHO. We lead a national Weitzman ECHO series. Actually, we lead several in multiple different topic areas. But if we're talking about really building capability to manage complex, vulnerable patients with conditions like HIV, like hepatitis C, or like opioid use disorder, e-consults are really helpful. We have a practice in El Paso, Texas, that's taking care of a largely migrant, uninsured population. Their providers got some basic training in Hep C, and they're using our e-consult platform to communicate with GI doctors to get advice about how to manage the Hep C cases that they're seeing. But they're also joining Project ECHO. because Project Echo gives you the chance to really get more in depth, to hear didactics from specialists, and to share cases, questions, and concerns with your colleagues around the state and around the country that are tackling the same sorts of issues. And I think if I were taking on the management of something complicated like opioid use disorder or HIV, and I wanted to do it within my FQHC, I would make it absolutely mandatory that the clinicians that were doing it join Project Echo on a regular basis, and that they had access to an e-consultant so they could ask their questions and get guidance and management about what they were doing. And I really think that's the cornerstone to any scalable telehealth strategy for taking care of complicated things. In the introduction, it was mentioned about taking care of LGBT patients. We worked with the CDC to lead a national learning collaborative that helped health centers that were interested in building their capability and competence to help take care of patients LGBT in the LGBT community. And we did the same thing. We did a learning collaborative to teach some of the core principles, and then we launched a Project Echo where they could learn and present specific cases, and we connected them to some of our e-consultants, endocrinologists for support with trans care, infectious disease docs for questions around HIV, around PrEP, and our complex chronic illness team for more general questions about all sorts of things. And by connecting them, the learning collaborative combined with those two, lead story in the Annals of Family Medicine, actually just this past week, is all about that collaborative and how these three components, the learning collaborative, the Echo, and the consult, work together to help health centers provide effective care to the LGBT community. All these tools have something in common. None of them are particularly complicated when it comes to technology. All of them are about connecting people. And I like to describe the strategy as moving knowledge, not patients. All of these tools and techniques and approaches are about connecting people so that they can share, discuss, and learn from each other, and really building a virtual learning community. So there are lots of echoes. University of New Mexico invented this concept all the way back in 2001 and have really propagated around the world. We lead one, actually several, in different topics, and we make it available to health centers around the country in the topics that you can see. Our most heavily subscribed focuses on pain management and helping health centers to reduce reliance on opioids. And we run that in parallel with a medication-assisted therapy echo, which helps providers who are waivered and want to prescribe buprenorphine. And then a whole variety of others, complex care management, LGBT. We have one for community health workers that specifically no doctors on that one. It's all CHWs and CHW experts. And then our eConsult Echo, which provides examples of common questions and consult submissions that we're getting, and then uses them as a teaching opportunity in a whole variety of different topics. So, and the last one that I want to mention, I'm hoping some of you have seen these or heard them. We run them every Wednesday. They're free across the country. That's our Weitzman Project Echo focus on COVID-19. Every Wednesday Eastern time at noon, starting in March, and we're going as long as we need to. We bring experts from around the country in various aspects of COVID-19. Some of them focus on clinical issues related to testing and treatment. Many of them focus on practice transformation. How did you convert your team-based care to a virtual environment? How are you doing telehealth using medical assistants and nurses? What's your testing strategy? Things like that. So it really blends. It's really this particular echo is intended to just be a lifeline for all of us trying to figure out what to do in this new COVID-19 world and beyond. And so if you're not familiar with them, the link on the bottom, you can see weitzmaninstitute.org/coronavirus. We'll take you to information on how to register if you'd like to join. And like I said, they're every Wednesday, 11 o'clock Central Time, 12 o'clock Eastern Time. So to kind of wrap up and think about resonance and think about harmony versus dissonance, I think in FQHCs, our providers, and myself included, I think sometimes feel, and I've had my frustrated moments, that we get the short end of the stick and our patients kind of get the shaft. And it is really frustrating to get emails like that one that I shared that just make it clear that the system, if there is such a thing, is really not in sync with our values and with the things that we're trying to do. And so, to me, one of the most powerful antidotes to create harmony out of that dissonance is through communication and connection. And I think probably every one of you knows this, that the America's FQHCs have been doing this work on the front lines for over 50 years in communities across the country. There are almost, I believe, 1,400 of us FQHCs out there fighting the same fight, wrestling with the same challenges, and trying to take care of the patients that we care about. And you can see we serve 23 million people. And each of the tools that I just talked to uses the simplest of technology. An e-consult is just a fancy email, and it obviously is a little more to it than that, but not much. Project Echo is just a video conference. And yet, in the Learning Collaborative is people coming together and talking about how to work together better and sharing best ideas. What they all have in common is they take these 1,400 health centers and all of the people taking care of our 23 million people and connect them to people who can help using the power of simple technology. The fact that I'm sitting in my living room in Connecticut talking to you in Arkansas is pretty remarkable. That's a powerful tool that we can use to create harmony out of the dissonance of a system that isn't aligned with what we're trying to do. And so if anyone wants to hear real harmony and beautiful music made out of a dissonant piano, Keith Jarrett, the Colon Concert is what it's called, and that's the piece that I was playing. But I would argue that as beautiful as this piece is, the music that we can make by working together and using some of these tools is even potentially more beautiful than that. And it's been, for me, just a beautiful opportunity to talk with you. I'm sorry I'm not there in person, but I'm looking forward to taking any questions that you might have and exploring, what we can do together as FQHCs. Powerful voice for our patients. Thank you, Lisa. Thanks so much for inviting me and giving me a chance to talk today.
Yes, absolutely. Thank you, Dr. Anderson. We really appreciate it. That was wonderful information. Y'all are doing so much. And I hope that our health centers will move forward with some of these things as well. I know that they participated in various echoes, and it sounds like you already have a partnership with one of our health centers around e-consults. So we're moving forward. So I've opened up the mics. Everybody that that is on here can open your own mic if you'd like to ask a question verbally or just make a comment to Dr. Anderson. Now is your time to do that. The floor is open. Or you can put it in chat as well if you don't want to verbally discuss. Do we have anybody that would like to make a comment? Question? So we have a comment, very engaging. Thank you for your presentation and love the analogies with the music. So yes. I do want to ask a quick question too, but we also have another one. Can we get a copy of the e-consult study for cost that you mentioned? Oh, well, I'm not sure.
There we go. Okay, thank you.
Okay,
I wasn't able to unmute. Lisa, I'd be happy to send a packet of the papers that I described. There were a couple mixed in there. I'll send them all, and you can feel free to distribute them to anybody who would like them.
Okay, great. Do have a couple questions here.
Yeah.
How would you recommend we contact you if we have an interest in further discussion?
So my email is Darren, D-A-R-E-N, at chc1.com. And Lisa, I think you have that also. If you don't get it down, I'll put it in the chat as well, but please just email me. And I have a whole team of people that can help depending on what you're interested in, and we'd love and definitely join that echo on Wednesday. They really are fun and informative. I know COVID has had ups and downs state by state, but last I saw, Arkansas was starting to experience a little bit more of a hit from COVID. So, and it really is. That I'm not just saying this as a pitch. They're a lot of fun. I lead them and facilitate them each Wednesday, and they're great fun. But definitely feel free to email me if you have any specific questions. Yeah, and I see that the question about partnership for e-consults is a great one, every single state is different. So the short answer is let me know sort of who who you are and where you're practicing and such, and we can see sort of what options are available. The thing that's been most successful for us is to really work with payers. In California, where we've been really busy, both the two major Medicaid managed care plans, Anthem and HealthNet, both pay for e-consults. And so we've partnered with payers to figure out a reimbursement strategy so that we can implement, or others can implement, the e-consult strategy in their own health center. Health centers that have a lot of value-based reimbursement or shared savings, shared risk, sometimes work directly with us. So there's a lot of different ways, and it really depends on where you are and who your payers are and such. So it really kind of takes a little bit more digging to figure out the best way to do that. But we're pretty creative, and there's lots of ways to make it work.
So if they have further questions, just reach out to you via email, Dr.
Yeah,
Anderson.
please do.
Okay.
Yep, I would love that.
All right. Do we have any other questions or comments anybody would like to make? All right. Well, if not, I just want to thank everybody for joining us today. Appreciate it, Dr. Anderson, for presenting, and you came through just fine. So yeah, there were just a few little hiccups, but everything else great. So I do want to let people know that we will be sending out an email with an evaluation. If you would please complete that. We really want your feedback. Also, if you were the one person that was actually on by phone, we cannot identify you. If you would please put that, your name and organization into the chat. That way we can make sure that if you need the CE, we can get that information, and also to get you the slides. So we have no way identifying you if you are by phone, unless we know your name. So we appreciate that as well. The video, this video will have enduring CE, so we're excited about that. So with the recording, we will be providing the recording link. Anybody within your health center can watch this video and get CE credit for up to a year. So we are excited about that as well. And so please share this with your colleagues and other peers within your health center and let them know it will be available for folks to watch down the line. So with that, we'll just say thank you again, and we hope to see everybody back next Thursday, same time, same day, and we appreciate it. Thank you, Dr. Anderson. Thanks for your time. Goodbye.